So my talk will have three parts. So in the first part, I will try to outline the clinical aspects of brain tumors, of CNS tumors, so that for you who don't know about this disease, you could kind of get a clearer picture of how big the problem is and what we can do, where are the problems and how we can do it to self-using this digital phenotyping tool, which I will review next. And in this talk, it would be understood as using smartphone to passively gather data to better inform clinical decision-making in medicine, particularly neuro-oncology. And so it's not very commonly used term as of yet, but the number of publications and data is growing that it can be an interesting and valuable method that could improve our patient care. And I will also discuss those evidences with what data is available at the moment for this technology to be used in clinical practice and probably more now in the research studies which are emerging. So first, when we speak about cancer, cancer is becoming important global health problem. It's among top 3 causes of death and morbidity and mortality worldwide, and especially in the Western world where we live. And the number of cancer patients is growing. So it is expected that, in 2016, there were 15 million cancer survivors, and this number is expected to almost double in the next 20 years. And the problem is becoming increasingly important because of a few problems. One of them is aging population. So we all get older and we die older now when compared, for example, 100 years ago. So, and as we know, cancer is more common in elderly patients. So our risk of getting cancer in our lifetime increases. So also population is growing. So we have more people who are potential cancer patients. Important thing is that we detect cancer earlier now using screening programs and because of better access to healthcare. So patients are diagnosed earlier, so they're treated with more effective treatment methods and they live longer. And of course, the treatment is improving for some cancers, for some common cancers, for example, for non-small cell lung cancer, melanoma. The treatment has advanced significantly over the past 5 years or so. So this also, it's good for patients, but we also have to deal with these long-term cancer survivals. And these patients who survive from cancer suffer from major challenges, such as long-term physical effects from cancer itself and from treatment side effects. So in neuro-oncology, patients, for example, when we speak patients with brain tumors, some patients can present with neurological symptoms that significantly disturbs their quality of life. But these patients live longer, so they have to deal with that. And that also costs for us as a society to maintain their quality of life as good as possible. In addition to that, these patients suffer from major psychological challenges, which are often under-addressed in standard of care of these patients. But that can impair their quality of life. So that also, I think, has to be addressed in order to optimize their quality of life and functional status. So when we speak about brain tumors, it's a heterogeneous and wide group of diseases. So it's not a one brain tumor, there are different types of brain tumors. So roughly we can say that there are primary brain tumors and brain metastases. So primary brain tumors are tumors that originate in the brain. It is like in 2020, for example, there were 83 new cases in the US. And most of them are non-malignant brain tumors, such as meningiomas, which can be followed and can be, sometimes we don't have to treat those patients at all, just keep an eye on them. However, 1/3 of them are malignant, and malignant brain tumors can we have no good cure for them, despite of extensive research. And another big group of cancer patients is brain metastasis. So as you know, different types of cancer can spread to the brain and cause brain disease, which needs to be treated. So we have treatment methods for that, but because of global burden of cancer is growing, so the number of patients presenting with these secondary metastatic brain tumors is also increasing. So here on the right side, you can see that, for example, also it's age dependent, that in kids, brain tumor is the most common type of tumor in children. So it's even more common than leukemia and other types of cancers. As we grow older, though, so brain tumor becomes less common disease, although we have more patients just because we have more patients with other types of cancer, such as breast, prostate, and lung, for example, which are the most common types of cancer. So prognosis largely depends on tumor type. So again, in the US, it's estimated that brain CNS cancers account for 16,000 deaths every year, which is not a huge number compared to other diseases. But as you can see on the right-hand side, in children, for example, brain CNS cancers in children is the deadliest type of cancer. So it's the most common. It's also the deadliest among all cancers in kids. Of course, other common causes are perinatal conditions, congenital abnormalities, and etc., and accidents. But when we speak about diseases, CNS cancer is a common cause of death in kids. Again, as we grow older, heart diseases, heart conditions is the largest cause of death, and cancer again is a small. CNS cancer, comprise a small fraction of an overall mortality picture. So again, as I said before, so survival of these patients depend on many things, and like histology grade, and it can be very variable. So it can range from like 8 to 12 months in malignant brain tumor patients, such as glioblastoma, and some of these can be curable. So meningiomas and pituitary adenoma. So I think for researchers and for who want to work in this field, it's important to understand that not all brain tumors are the same. They are very different diseases, and we have to look very carefully when we speak about them. So typical diagnosis of brain tumor patients, so they usually present with some symptoms. So for example, headache is the most common symptoms. Some brain tumors can cause seizures, some focal neurological deficits such as weakness, numbness, etc. And importantly, some patients can be asymptomatic, so they present their cancer is discovered incidentally. So they present with other conditions. For example, with suspected stroke, we do imaging studies and we find that the patient has a brain tumor or benign, mostly benign brain tumors such as small meningiomas, and then we just follow them. Oftentimes, we don't have to do anything. Imaging is the main diagnostic tool for us, so we can do imaging, and we also have to be careful. For example, on top row, we can see 2 cases of brain tumor, which look very similar. So as you can see, this bright spot between the eyes on both patients looks like tumor, but these tumors are different. So one case is meningioma, another is pituitary adenoma. So we have to also carefully analyze those imaging studies. And in the middle row, we can see, for example, a patient who presented with confusion and headaches, and imaging was done, and it showed this, ring-enhancing lesion, which on MRI looked bright and has increased perfusion. So it was suggestive of brain tumor, and patient also had a history of melanoma. So it was biopsied, confirmed to be melanoma brain metastasis. So we have to be also careful when seeing a patient, talking to a patient, and examining all his history and doing tests that needed not only brain imaging. And of course, biopsy is the gold standard. So when we do a surgery, take a small piece of the tumor and can tell what type of tumor that is. Again, treatment options are different. So as I said, for benign brain tumors, we can just do observation. So we do brain scans every 6 months, every year, and see if that tumor is progressing. If it's changing, we can talk to a patient and then talk about possible treatment options. Surgery is gold standard, so it's what neurosurgeons do. They take out the tumor, either do gross total or subtotal resection or a biopsy, so we can take the whole tumor, part of the tumor, or just a small piece of the tumor. Important treatment is radiation therapy, which also come in different shapes and forms, and we can tailor the treatment for a patient. So it ranges from whole brain radiation, where we just irradiate the whole brain. It's kind of was standard of care few decades ago, and now we can target those lesions more precisely using, for example, radiosurgery, where we can be very precise and very accurate. However, it also has limitations, and so we have to choose the treatment based on a patient. Also, important thing is systemic therapies and chemotherapy. So patients with non-brain cancer who has brain metastasis, it's important to control the disease. So if we, for example, don't control the disease, then cancer will continue to spread to the brain. So it's futile treatment. over and over again. So we need to control. And as I said, there are some major advances in this field that helps to control the disease. Unfortunately, for primary brain tumors, there is still no real breakthrough. So there are works happening, studies happening in clinical trials, but treatments did not change for the last 20 years. So we still use the same protocol, and survival is better than without it, but it's still not, it can be substantially improved. So in this sense, we have to also consider clinical trials for these patients and other treatments that are not standard of care, such as laser therapy. This is in top row, a patient we treated in Boston, a young man, 20s, presented with neurological symptoms, and he was found with this, if you can see here, small tumor, which we basically biopsied and then burned using lead. Another treatment is FUS, which I will briefly talk later, and different clinical trials about for treatment of these patients that are happening worldwide. So here's, for example, we also have to be creative and when doing research, and we can integrate different treatment therapies. So for example, focused ultrasound for blood-brain barrier opening is a treatment when we use MRI, we use very focused ultrasound to open blood-brain barrier so that so that chemotherapy could penetrate to brain better. So, and hopefully that would improve treatment efficacy and safety for these patients, because we have to give potentially smaller dose, smaller systemic toxicity, so and brain penetration is greater. So that's a treatment. It's also still in the phase of clinical trials. It's still not a standard of care, but it's one of those promising treatments from neurosurgical field. And some patients were treated, however, in still like small proof of concept trials, and larger trial is ongoing right now. So when we speak about treatment, it's important to choose the right treatment, right? So as Mark Twain said, like if you only know how to use a hammer, everything starts to look like a nail. So that's not the case should not be the case in neurosurgery, neuro-oncology, because we have different treatments and we have to choose wisely which treatment we can use. And we have to consider the following characteristics, which we discussed before. So like it's primary or metastatic brain tumor, tumor grade, tumor location. Sometimes, for example, even benign brain tumors in very eloquent areas cannot be safely resected, not causing significant problems to patients. So we have to be careful about that. We also have to think about patient's age and functional status. So for example, we want to be more aggressive in younger patients, whereas, for a patient who has lots of comorbidities and after, for example, liver transplant and brain tumor, we probably wouldn't be so aggressive for this patient. And we have to talk to them and understand their goals of care. So what they want to achieve with their treatments, because everything has risks and benefits, consider side effects versus what we know about efficacy of the treatment. And also depending on a center, we have to know what technology is available, what clinical trial options there are, so that the patient could be counseled appropriately. So for example, here's one of the patients just to illustrate that decision-making in these brain tumor patients. So this is a high-functioning male in his mid-40s, a professor, right-handed, right? So he presented with seizures, and as you can see, this in the left temporal parietal region, there is this tumor here. So he's right-handed, so we expected that his language is in his left hemisphere. So patient presented to us, and he was highly functioning, right? So we wanted to preserve his functional status as much as possible, considering that it looked like a low-grade brain tumor. So we did for him a tractography, and really we saw that important brain tracts surround the tumor from all sides. So you can see corticospinal tract, arcuate vesiculus, IFOF, that basically surround the tumor, and we had to look for we have to consider about that, because we can take out the tumor, but we also would take out his tracts, and that would cause significant morbidity for a patient. And this patient also was multilingual. He spoke like 4 languages fluently, so we did his language mapping, and it turned out that its brain is very eloquent. So he knew a lot of languages, and as we grow older, so as we were young, right, when we learned the languages, only a small part of cortex is needed to be used for that function, right? But as we grow older, the more and more cortex needs to be activated to use that language. So this guy, he had a like 4 languages. So lots of his brain was very, you can see it's very active when he does language paradigms on functional brain MRI. So we talked to him and like how we can help you. So he wanted to preserve his functional status so that he could work his continuous academic career. So we decided to do like a staged resection, subtotal resection of the tumor. We talked to a patient that we won't do we cannot do subtotal resection safely. So we did subtotal with intraoperative MRI and different mapping techniques in the OR. And it turned out and also because we knew that, other treatment options are available. So he was diagnosed with grade 2 glioma, so which is considered low grade, but what the problem is that they tend to progress to high grade and malignant brain tumors. And the patient afterwards underwent a radiation therapy and chemotherapy. So that's one thing. Another illustration is a patient who presented with Cushing's disease. She's in her late 30s. She had infertility. She wanted to become pregnant. So she presented to us, and before that, she had transplanted, so resection of this CNS tumor of pituitary gland, and experienced recurrence. So for these patients, we did radiosurgery because she already had a surgery, which was kind of failed. And so, we knew that surgically we cannot take out the tumor. So we decided to pursue with SRS. We treated the patient, and it took time for her to achieve endocrine remission, but eventually she did. And she was off medication, and her Cushing's disease was well controlled and arguably cured. But still, she will need follow-up. So in this case, you can see that we can use surgery, radiation, and medical management to treat these patients, and to think wisely what treatment we want to use, considering tumor location and patients' wishes, and also known efficacy and known data about those treatments. So that's about treatment. So the standard of care now, when we see these patients with brain tumors, right, we typically follow their symptoms and progression, and we do neuro exam here, as you can see it here. We see patients every so often in the hospital, depending on the disease. In the hospital, when they come to clinic, we do neuro exam and we do some sort of brain imaging, because that's kind of the best test to see the status of their brain disease. Treatment options, so surgery, which helps establish diagnosis, which typically happens once or sometimes twice, depending. And also first-line treatment is chemotherapy and radiation therapy, so we speak about malignant brain tumors. And also when patients fail all of the above, which is often inevitable for patients with malignant brain tumors, they are offered some sort of clinical trials because first-line treatment was not effective. And most of care takes place at home, right? The patients usually come to the hospital only for surgery, and all other treatments can be outpatient, so they are at home. So we don't see those patients every day. We see them every so often. And as you can see, this in orange color, you can see these blind spots. So times when we don't see a patient, and this is important to consider because if we don't see a patient, we don't ask him the right questions, we really don't know how he's doing, right, at every moment in time. So that increases the risk that we underassess really their quality of life and their side effects of chemotherapy and treatments that we give him. Also, it can delay diagnosis of disease progression. So for example, a patient, in this timeline, right, the patient had all his treatments, he was at home, he saw his doctor, and he started feeling some subtle symptoms of neurological decline, and his next visit was scheduled but a few months later, and only when patients started feeling severe neurological symptoms, he was seen by a doctor, and then the disease was not surgical anymore. So basically we missed this opportunity to treat the patient on time. And also once patients go to, for example, in the same accounts for patients who fail treatments, we see this failure later, and we cannot refer patients to clinical trials at the right time because we just don't see how he's progressing because he's at home. So these are limitations of current care, and as you could see there in that example, so current care is fragmented, so we see only patients at certain amounts of predefined time intervals. It provides only snapshot of data. So basically we see patients in clinic, which, we have 10-15 minutes for a visit, and we don't always have time and tools to write the right questions for a patient. It also happens in a hospital, not in their home environment, because patients, they typically don't like hospitals. No one likes hospitals. But when they come, sometimes they can try to kind of hide some symptoms because they want their doctor to like them, etc., and what have you. So it's not natural environment. So we don't really see how the patient is doing at home. We ask him, but then it's also subjected to recall bias and other biases that patients might have. Also, we don't really do functional status assessment. That's kind of the only thing that's done in clinic. It's subjective, and it's also prone to recall bias. Typically, we don't assess quality of life, cognitive function, and other mental health problems in the hospital simply because we just don't have enough time or resources to do that, and we cannot really address that in a timely manner. And that also limits our prediction of this patient's trajectory. So we look at clinical trial data and we try to extrapolate this patient's clinical course, but I will show you further that it's not always the case, that this clinical trial data might not be accurate for a particular patient. So this is that example. So a recent study published last year in neuro-oncology practice, what they did, they tried to compare 3 different methods of quality of life assessment in patients included in large clinical trials. So this was like a meta-analysis, individual patient data analysis of 15 phase 2 or 3 randomized clinical trials that included almost 4,000 patients. And what they did, they compared the quality of life scores before inclusion in clinical trial and at first follow-up visit. And what they found really that if you look at the quality of life data as at group level, and if you define change in quality of life as 10 or more points change in any of the quality of life subscales, what we can see that all scores were statistically significant, right? So all quality of life appears to be improved in these patients. However, only one symptom, which is hair loss, was changed clinically significantly, so by 10 points or more. So suggesting that although we can see the statistical significance in large because it's very well-powered study, right? But clinically, these numbers are not relevant. So hair loss, for example, in these patients can be explained by radiation therapy. That it's malignant brain tumor patients that are radiated and they lost their hair. But other symptoms, although that's changed again, statistical significance does not always mean clinical significance in medicine, which should be considered as well. And if they they looked at the number of patients whose quality of life changed by these 10 points or more. And what they found that the majority of patients remained really stable during the course of the treatment and participation in clinical trials. And some patients improved, some patients deteriorated. So you can see all these different fluctuations in these quality of life scores. Although a clinical trial paper that's published in the clinical trial, it says that quality of life, the treatment improved or did not change quality of life. So typically, that's not necessarily the right interpretation of this data. And if you look at a patient level, that was really what digital phenotyping is doing. It tries to look at patient at his or her level of functioning, rather not at a group level. What they found that the majority of patients either improved or deteriorated in any aspects of their quality of life. So things happen. So something improves, some things decline. That's how most patients do. 7% of patients experience decline on all aspects of their quality of life. And only 7% of patients improved or remained stable during the course of this clinical trial. So meaning basically that, it happens. So some aspects improve, others decline, everything's happening, and we have to see a patient, we have to follow the patient, not the patient group, and to make the best informed decisions for this particular patient. And important clinical factors were not associated with this observation. So meaning that, it happens in patients with benign and malignant brain tumors across functional status grades, across age, and what have you. So it happens for all patients, for all neuro-oncology patients. It's just fluctuation of their clinical, of their quality of life and perceived health status. So just about the COVID, and I think COVID was a good point that it provided some new. So we know that cancer patients are more prone to morbidity of COVID. Their vaccines are less effective. So these patients, in particular, this telehealth is becoming important in these patients at this point. So digital phenotyping is what I described before. So it's using cell phones to follow patients and to describe their level of functioning. So it's very temporally dense data, very high resolution data. We use phone for a patient, so we all use phone in a similar way. So we know how we are changing over the course of the disease of our lifetime. And that gives us precise and temporal dynamic disease phenotype. So for every one of us, it's similar. And smartphone use is growing substantially in the world. So almost 90% of Americans have cell phones. So, and also smartphone is a powerful sensor. So we can track GPS, accelerometer, geolocation, gyroscope, call logs, et cetera, et cetera. And there are some studies now showing that it is associated with some important behavioral outcomes, which are important for patients. And there is some studies in cancer patients and patients after cancer surgery and mental disease that these phenotypes can be clinically meaningful. And so it can predict, like, not only, so these physical properties of sensors, what we measure can really correlate strongly with behavioral changes of these patients. This is just to repeat that, yes, it's important. So, and there are some patients in cancer patients, for example, this study in 10 patients with incurable gynecological cancer, they used this platform to monitor patients. What they found that, for example, this patient, she had a kind of, her pattern was stable 3 days before she started experiencing nausea, severe nausea from cancer chemotherapy. And you can see that it's changed, right? So this patient's use of cell phone has changed over time. And we can measure that. This is digital phenotyping tools. So can a larger study so far in surgical patients, in patients 62 patients who underwent surgery for different cancers. They followed these patients for 140 days, and what they found that patients who experienced post-operative events where baseline activity was lower. So basically, we could see at group level that patients who experience post-operative complications, they start moving less so, and they're, as compared to patients who did not experience those complications. So their activity remains kind of in their baseline or above their baseline and steadily improved. And here is, for example, an illustration for a patient who experienced abscess. So this red curve in the middle, so the patient really was kind of more active than baseline, which is in blue. No post-operative events, but his activity suddenly dropped, and he presented to a hospital and had to undergo urgent surgery. Some brain tumor patients' data is limited. Just one study from our friends in Boston who studied 8 patients with different brain tumors, followed for 190 days, and they found that it can be used to correlate with that. Important part is that we can also integrate that with mHealth different interventions. So here's a meta-analysis we published this year in patients with cancer. So we can study 25 studies, 17 randomized clinical trials, and 8 pre-post studies. What it showed basically that mHealth interventions, so basically different interventions using smartphones, can improve quality of life of these cancer patients. So in this context, we developed our tool, which basically what it does, and we're testing now in clinical trials that integrates passive data, also includes active data, and also clinical data. And so that we hope that it will allow this monitoring of these patients and improve their care. So we are doing now clinical trial in patients undergoing radiation therapy for different brain cancers. And unfortunately, we still don't have data, but hopefully we'll have it soon. We still have a lot of challenges to overcome. So privacy and security. So some patients don't want to be followed. Some patients don't have enough digital literacy. There's also concern about data sharing, and also it's large data sets, right? So it's a lot of data, very dense data. So that's a problem, also moving those data sets in the clouds and what have you. Still evidence is limited, but it's accumulating that it can be valuable. So more clinical trials are needed to do that. So to conclude our talk, so basically, I think that digital phenotyping can help to address using passive data for patient monitoring can address some gaps of current clinical care, and improve patient care overall. It can be used to monitor patients at their home environment, which is very important. It also can be used for prediction modeling. So you could, if you have enough patients, you can predict which patients will deteriorate based on their, for example, 3-day post-operative course, predict their complications. And also can be used to optimize clinical trial data collections, and also it can be integrated, for you guys with other methods, such as what you are doing. So if you could have very precise behavioral patterns, and we can, maybe that could help learn us better how brain is really working and which functions are, where disease in certain areas can affect different brain functions and behavioral phenotypes. And thank you very much, and look forward to questions.